Mike Gibson, Usman Baber, coming to you live from SCAI 2016. Usman, talk to us about the Prometheus study. You know, we usually think of ACS as old people, but you did a very interesting study looking at the elderly.
Right, thanks Dr. Gibson. So the Prometheus study was about 20,000 patients, real-world cohort, 8 academic medical centers in the United States, and what we wanted to do is leverage that large sample size to ask an important question about young individuals, just as you mentioned. And so we chose an age of less than or equal to 55. Most studies in ACS or PCI patients are in their mid-60s to late 60s. And so we had about 5,000 patients, about 4,800 to be exact, who were under the age of 55, presented with acute coronary syndromes across these 8 academic medical centers and had a stent implanted and had longitudinal follow-up out to 1 year. And so our interest was understanding the profile of these patients stratified by sex, the use of prasugrel stratified by sex, and also to understand whether or not there were differences in outcomes and the efficacy or safety of prasugrel in this very young population.
And in general, how did they compare to the elderly? Do they tend to be more smokers? Do they tend to be more male? Are there differences?
Yeah, so it's interesting. In terms of the breakdown by sex, for example, so out of this population, about 5,000, 3,800 were men, about 1,200 were women. So we get a similar kind of breakdown, 25% or so were women. That's number one. Number two, if you look at BMI, now granted this was a US cohort, so BMI is a little bit higher, but interestingly we found the BMI in the women was a little bit higher. Traditionally when you think about ACS, PCI population, you get lower BMIs in women.
Yes.
We found that the burden of diabetes was 27% in the men, about a little over 40% in the women. So you still see that gradient in terms of diabetic enrichment that is higher in women compared to men in this young population. PAD was about...
Probably because they have some endogenous protection from their hormones, so therefore they've got to have this other risk factor.
Exactly,
right?
and perhaps indeed, like you were just saying, the risk is accentuated. These young people, the average age of which in this cohort was 48, who are coming to the hospital with an acute coronary syndrome and coming and getting a stent, are probably certainly selected out to be a unique, very high-risk population. But in terms of the breakdown and risk factors by sex, we see much the same that we see in older cohorts, namely women had a higher prevalence of diabetes, women had a higher prevalence of PAD, about 10% compared to about 5% of the men, and the rates of, or the prevalence of CKD was also double in women compared to men, about 13% versus 7%. So even in this young population, we see the same sort of gradient in terms of risk profile that we see in older patient populations.
And how did they do?
Right, so unadjusted outcomes in women were worse compared to men for both bleeding and ischemic outcomes. So our primary outcome here was MACE, which was a composite of death, MI, unplanned revasc or stroke. Women at 1 year, 22% event rate, quite high. Men, 16%. So you do see very high event rates, like kind of what you were alluding to earlier, that these are probably uniquely enriched patients with comorbidity. But the women, about 6% on an absolute scale, higher risk for events at 1 year on the ischemic side. On the bleeding side, it was about 3.2 versus 1.5%. So bleeding rates weren't super high, but still higher in women compared to men. And when we did some adjustment approaches to adjust for these outcomes after accounting for the baseline differences, the differences were attenuated. The point estimates favored higher adjusted risks in women, but probably because of the sample size was a little bit smaller, the results were non-significant. But certainly it speaks to the fact that these young patients are high risk, speaks to the fact that the differences in risk profile are preserved with respect to higher risk in women compared to men. And third, that outcomes in women certainly appear to be worse as well.
10 years from now, when we repeat the study and everyone's genome is sequenced, we'll be able to say, well, it was because they had this genetic variant probably.
Yeah, and that...
These young people.
Exactly, and that kind of speaks to the other issue we were looking at, which was the use of prasugrel.
Yes.
And do we see differences in the overall Prometheus cohort? 1 out of 5, and again, these are ACS patients, troponin negative, troponin positive. Only 1 out of 5 got prasugrel. In this study of younger people, 31% of men were given prasugrel at the time of discharge, but 28% of women. It's not a huge difference in absolute terms, but it was statistically significant. It's an interesting insight that despite higher ischemic risk profile, more diabetes, more PAD, and these are young women, these are women in their 40s, and they're still less likely to get a potent antiplatelet therapy. And when we looked at the prevalence of prasugrel use as a function of thrombotic risk factors, in other words, looking for a risk treatment paradox, we certainly observed that in the women. Women who had none or about one thrombotic risk factor, about a third of them got prasugrel. But when you look at women who were enriched with multiple thrombotic risk factors, about 15%. So it drops off substantially. So
crazy.
it's interesting insight in how we, as
we've always
clinicians, are
seen
making
that.
decisions.
We've always seen that. You know, the highest risk people don't get cath, and you know, then the highest risk for thrombotic doesn't get the more potent antithrombotics. It's a very bizarre paradox.
Very bizarre paradox that, and one would think that perhaps those paradoxes may be less apparent when you're dealing with younger people, because one thing we're usually afraid of is the elderly and the risk. BMI is a big one, but like I was saying, the BMIs were, you know, pretty comparable, even higher in the women here. But some of the classic reasons where we may be sort of averse to give prasugrel really didn't play a role here. Nevertheless, you still see the exact same paradigm that, as you mentioned, we see in other, you know, sort of disease spaces.
Well, Usman, tremendous insight into a group of people we often don't think a lot about,
Absolutely.
the elderly. Thanks for sharing with us, and thanks for joining us here live from SCAI 2016.
Thanks, Dr. Gibson.
Thanks. All right.